I'd like to welcome Dr. Loren Harris, who's a physician, who's Chief of Thoracic Surgery at Maimonides Hospital. Thank you.
Well, thank you. It's a pleasure to be here. I see a lot of young faces out there. And what I'm going to just speak on briefly is something that we at Maimonides and really all over the country and probably all over the world are very, very excited about, and that is the recent advent and approval of lung cancer screening. So I just wanted to kind of go through the issues with you. You go ahead. Well, I mean, what is the problem? Well, lung cancer is the leading cause of cancer death. Not only in the United States but worldwide, and it actually kills more people than the next three cancers put together. Okay, we all hear a lot about breast cancer and prostate and colon cancers, and those are big problems, and they clearly need to be addressed. But you really don't hear a lot about lung cancer and lung cancer care in the media. Well, you know, there's over 1 million new cases worldwide, about 200,000 or so here in the United States. And worldwide, it kills close to 1 million people a year. So that's a huge number. It is the leading cause of cancer death in men and women. It's been the leading cause of cancer death in men since about the mid-50s, and in women since about 1986. And the reason for that is because women weren't, the idea of a woman smoking was really not acceptable until, the 40s, 50s, and into the 60s. So when the 80s hit, so did lung cancer in women. Again, there are well over 300,000 people in the United States living with lung cancer. And the interesting thing about lung cancer now is we're actually talking about surviving with lung cancer. We never really used that phrase before. I don't know if anybody here remembers who Peter Jennings was. He was the anchor for ABC World News at night, and he developed lung cancer and was dead within 6 weeks. So you don't see a lot of long-term survivors, but that's actually changing. We're starting to see people surviving out many years. And of course, the idea of treating lung cancer, not only surgery, but chemotherapy, radiation therapy, and long-term care is very, very expensive. As you see here, close to $10 billion, okay, every year. And unfortunately, you can see that $10 billion is spent on lung cancer every year, and if you take all comers with lung cancer, only 15%, roughly 1 in 6, will be alive 5 years later. So that's not a lot of money, a bang for your buck. So this kind of puts it into perspective. What you see here is lung cancer, breast, prostate, and colon cancer. Okay, the 4 most common cancers that we deal with and that you hear about. The bar on the left is the number of cases. The bar on the right is those who die from those cancers. And you can see that the vast majority of patients with breast, prostate, or colon cancer live with the disease or die with the disease. Whereas with lung cancer, the vast majority of patients who are diagnosed will ultimately die from that disease. So in essence, for most patients, it's a death sentence. Okay, it's just a matter of when. Okay? So what are the risk factors? Well, we all know the risk factors. Okay, the main risk factor, and unfortunately I did see some people smoking outside, the main risk factor is smoking. And it's clearly related to how much you smoke and over how long a period. Okay, the more you smoke, the higher your risk. Okay, and the good news is that nationwide the prevalence of smoking has dropped significantly because of advertising and a lot of the media and other things you hear and read about. but I still remember as a child cigarettes being advertised on television, and that was put to an end, and that really helped. So nationwide, it's about 18% of Americans still smoke, okay? If you go to Europe, it's actually much higher. But there are other risk factors. You see here COPD, which stands for chronic obstructive pulmonary disease, patients with emphysema, chronic bronchitis. That is in and of itself a risk for lung cancer. Patients who have emphysema will have a higher risk of lung cancer. And you say, well, most of those patients have smoked, and that's true. Most of those patients have smoked, but they've been able to tease it out where they know that it, meaning COPD, is an independent risk factor. Living in urban settings, unfortunately, that is, it makes your risk a little bit higher. But most of us, if you were to look at your lungs right now, most of us would have little black dots all over the lungs, and that's just what we call anthracosis, and it's actually secondary to inhaling various things over your lifetime. If you grew up in the Andes Mountains and never had an exposure to any type of urban or suburban environment, you wouldn't have that. But for the most part, that's not a big issue. You can go down, you can talk about secondhand smoke. Secondhand smoke actually is considered a risk factor for lung cancer. The problem is that it's very hard to quantify how much smoke you were exposed to over how long a period. So it's very hard to put that into a category in terms of risk. Radon gas, which is pretty much ubiquitous, certainly in our area on the East Coast in soil. That's not a huge exposure, but I want you to think about genetics, and genetics is becoming much more of an issue, not only in the diagnosis of lung cancer, but in the treatment of lung cancer. And I'm not going to talk about that today, but genetics is very important. Certain people smoke for their whole lives and never get lung cancer, never get emphysema. There are other people who smoke for a short period of time and get terrible emphysema and ultimately wind up getting lung cancer, and it's all based on genetics. The other thing is that about 15% of our patients have never smoked, and we're seeing a lot more of that over the last several years, especially in young women, and I'm not really sure why that's true. Okay, so you see here, this is basically what I've been talking about. The longer you smoke, the higher your risk. If you are a lifelong non-smoker, you can see your risk isn't zero, but it's very, very low. Whereas if you continue smoking up to the age of 75, you can see that it's logarithmically higher, your risk of lung cancer. So I'm sure I'm not telling you anything you didn't know already, but there it is. So what we're so excited about, and what I came to really talk to you about, is the idea of lung cancer screening. There have been multiple studies done over the last 40, 50, 60 years trying to find a screening test for lung cancer. And it's never been shown that chest x-ray, for example, routinely performing a chest x-ray on patients who you think are high risk made any difference in the survival of those patients. Well, this is the National Lung Cancer Screening Trial, and this was published in 2011 in the New England Journal of Medicine, and it was a huge trial. You can see that we're talking about 50,000 patients who fit into a category of high risk, and these are the categories we're talking about: 55 to 75 years of age, 30 or more pack years of smoking. A pack year is if you smoke a pack a day for 1 year, that's a pack year. Okay, so people who smoked 1 pack a day for 30 years have a 30-pack year history of smoking, and there's various numbers of ways you can get to that number. They are either actively smoking or quit within the last 15 years, and I think the reason they did that was because if you do quit smoking, your risk of lung cancer does go down. And again, it never reaches the baseline where it would have been had you never smoked. But it does go down significantly. So people who have not smoked more than 15 years generally are not in the high-risk category. So those were not included. And they use what's called a low-dose CAT scan of the chest. And low dose means a very small amount of radiation. It's 1 to 1.5 millisieverts. And just to put that into perspective, if you get a mammogram is roughly the same amount of radiation, maybe a little bit less. If you fly from here to England, you have roughly a half to 3/4 of a millisievert of radiation exposure. So this is an exceedingly small amount of radiation. Okay, so what they did was they scanned half of these patients, and the other half, just as a control, got plain chest X-rays. And they did this for 3 years, and what they found was that there was a 20% risk, a 20% reduction in the risk of death from lung cancer in the patients who had the CT screening as opposed to those who didn't. And oddly enough, there was almost a 7% reduction in all-cause mortality, meaning that some of these scans picked up diseases that would have ultimately killed the patient, and they were treated, thus avoiding the death from that other cause. So, and you know, one of the criticisms of the study, or one of the issues about the study, is it's felt that had they screened longer, these numbers would have been higher. Okay, so this was a very good proof, really, that lung cancer screening does work, and it works as long as you stick to a high-risk group of patients. So this is kind of how lung cancer breaks down right now as we sit here today. 220,000 new cases. About half of them will present in what's called stage 4, or really not curable. Okay, these are patients who are basically treated with chemotherapy and supportive care. About 25% present with what we call locally advanced disease, or stage 3 disease. These patients actually can be treated with multimodality therapy with the idea of curing them. Although the cure rate is quite low, the multimodality treatment of these patients does actually improve their overall survival. It's this bottom 25% that we're talking about here. These are patients who present in stage 1 or stage 2, and these patients are treatable because they can have surgery to remove the tumor. As we stand here right now, there's only one way to cure lung cancer, and we you know, those of us who treat lung cancer don't really use the word cure very often, but there's only one way, and that's surgery. So these are go ahead. So those are the patients you're gonna save, but it's only 25% of the overall group. So you know what you're talking about is a relatively small proportion of patients. Go ahead. So basically, with lung cancer screening, what we're looking at down the line is picking up cancers that were ultimately not going to be picked up. And the one thing I should say, and I'm sure Jody will correct me, is that in order to get screened for any cancer, that means that you have no symptoms. And the thing about lung cancers rarely cause symptoms until they get to the point where they're not curable anymore. Okay, they cause bleeding, or they cause obstruction or pneumonia. A lot of times those patients are no longer curable. Okay, so in order to get screened, you have to have no symptoms. Okay, so there have to be a high-risk group of patients who are presently not having symptoms. Okay, so with lung cancer screening, working it out in our population, what we're looking at is to kind of try to flip the paradigm here, so that we increase significantly the number of patients who wind up in the surgical group, because those are patients who can potentially be cured. So whereas what I told you before, only about 15% of lung cancer patients will survive 5 years if you take all comers. With this type of flip of the paradigm based on lung cancer screening, we may be able to improve that to a 65% 5-year survival for all comers. In other words, we'll be much closer to colon cancer and breast cancer than we are now. Okay? And that means we'll potentially save hundreds of thousands of lives every year. Go ahead. So after the publication of this of the study, most of these groups who are concerned with lung cancer came out in favor of lung cancer screening, the most important of which is at the top, which is the U.S. Preventive Services Task Force. They gave lung cancer screening the same grade of importance as mammography for breast cancer. Okay, and in fact, there have been several financial publications in the recent past looking at the cost per quality of life year saved for breast cancer, prostate, colon, and lung. And actually, believe it or not, lung was the cheapest in terms of how much you had to pay in to save a year of life. So it certainly financially makes sense, and now from a cancer standpoint, it makes perfect sense. And late breaking news is on Monday, the CMS, or the people who control Medicare and Medicaid, have decided to pay for Medicare patients who qualify for lung cancer screening. And the good news is they're going to do it in a very controlled way with an ongoing database and ways that we can study those patients so that we can actually hone it down to even smaller group of patients and thereby improve the amount of money that we have to pay to save lives. So as of right now, they will pay for those Medicare patients, and that was very important to us because even though the Affordable Care Act was going to pay for this, they were only going to pay for it up to the age of Medicare, which is 65. So if you look at lung cancer, the median age of all new lung cancer patients is 70 years of age. So paying for lung cancer screening in a 55-year-old doesn't concern us as much as it does for a 70-year-old. So that was a very, very important change, and we're thrilled that CMS has now agreed to pay for this. So next slide. So this is what I was just saying. So they decided to pay for it. There are going to be specific criteria, and the good news again is that there are going to be specific quality criteria. So not everybody with a CAT scan can just go ahead and screen people. You won't be able to drive through McDonald's, get your Big Mac, and then get a screening scan. So because that's going to lower the quality of the results. And somebody might say, well, I don't really qualify, but I think I should get a screening anyway. Well, no, you shouldn't. Okay, so I think that this is really going to work in a very positive way for those of us who are involved with taking care of lung cancer patients. Go ahead. So at Maimonides Medical Center, specifically, we do have a multidisciplinary team that includes thoracic surgery, radiology, oncology, pulmonology, and we review every single case before they get treated. The data on multidisciplinary treatment of cancer has shown clearly that about 25% of the time when a case is reviewed by a multidisciplinary board, the care changes about 25% of the time. So it's not whoever gets to the patient first treats them. It's based on data and based on guidelines, and that's the way we do it at our institution. We are presently doing lung cancer screening, and we are using the NLST criteria very much like the CMS guidelines are going to include. We do it at little or no cost to the patient. We do have funding for a certain number of cases, a certain number of scans, and any suspicious nodules are reviewed by our multidisciplinary board or someone on the team to make sure that the plan is correct. And we also include a smoking cessation program because any comprehensive screening program will have to include smoking cessation. And as you might guess, since smoking is the leading risk factor for lung cancer, the best way to avoid lung cancer is to never smoke or to quit. All right, so we believe very strongly that smoking cessation should be the part of what we do every day, and so we do that. Go ahead. So this is the team members, myself, Jason Shaw is my director of minimally invasive thoracic surgery, is also he and I administer the lung cancer screening program together. Igor Britchkov is also one of our very, very good thoracic surgeons. Esther Mintz, our nurse practitioner, and of course, Jody Steinhardt, who's going to be speaking to you in a moment, is our lung cancer screening coordinator. Go ahead. So basically, you should think about this. I know that everybody in this room knows somebody who smokes, somebody who fits into these categories. And the whole idea is to have them give us a call, and we will screen them to make sure that they fit into the right category to get screened. We're not trying to just do scans on everybody who walks through the door. We turn down a lot of people based on the fact that they don't fit into those guidelines. But you have to make the call. You have to say, yeah, I fit into that group, or yeah, my aunt fits into this group, my uncle, my mom, my dad. And it's very important that they get screened. You know, you could save someone's life. So I think that's very important, and this is something that you all should think about. And any of you in the audience who smoke, you got to stop, okay? And we can help with that too. We have a smoking cessation program. It's very simple to do, and it doesn't require a lot of time. And it's actually been shown to significantly reduce or significantly cause people to stop smoking. So with that, I'm going to introduce Jody Steinhardt, our coordinator for our lung cancer screening program. She's really done a super job, and we are now certified. We're now a Center of Excellence for the Lung Cancer Alliance, and we're going to be, hopefully this spring, we're going to get certified by the American College of Radiology as a Center of Excellence as well. So she's spearheading those projects. So Jody?
Thank you. Good afternoon. Just curious, by a show of hands, how many people here are health-related majors? Cool. How many of you are nursing majors? Just a couple. Just quickly call out, what are your other majors, the health-related majors? Health promotion. Oh, cool. My passion. Okay, so as Dr. Harris said, I coordinate the lung cancer screening program. Now, looking around this room, not a lot of you, I would say probably very few of you, would actually meet the age criteria for screening. And so I'm going to change this up a little bit in terms of our discussion today about what this means for you as health promotion and nursing majors, who is the overwhelming majority here, if I saw the hands correctly, and how you can, and how this would fit into your studies and your lives going forward. So next slide, please. All right, so as Dr. Harris mentioned, we have a really comprehensive program. We have experienced radiologists, which is very important because you don't want someone reading a lung screening CAT scan who's never really read them before. I don't know if any of you have ever seen a CAT scan, but it looks like there is a lot of snow in the CAT scan. That's what we call noise, and you have to be able to spot the nodules through the noise, and you have to really know what you're looking for. And sometimes these nodules are 2 millimeters big. I mean, we're talking tiny little things, and you have to be able to spot them and document where they are in the lung, not just that they're there, because when you follow up, you have to be able to tell a comparison of what it was before and what it is now, and the software actually measures these tiny little things. So you want a radiologist who has lots of experience. The American College of Radiology, the ACR, states that it has to be somebody who reads 300 lung screening scans, which are low-dose scans, in 3 years. So we're not talking somebody who reads one every 3 months. You're talking about somebody who reads several of them every week. Top-notch thoracic surgeons. We at Maimonides have 3 thoracic surgeons who are well-versed in the latest minimally invasive techniques. They're constantly upgrading their skills and going for conferences, and really, and yes, I'm using the term, on the cutting edge of what it means to be a up-and-coming thoracic surgeon. Knowledgeable pulmonologists. Pulmonology is a really big deal when it comes to lung screening because you're talking about somebody's lungs, and if somebody has lung cancer and they get a resection, then their whole breathing pattern changes. You need a pulmonologist who knows how to treat these people and to get them going and get them back into the swing of life. We have an amazing nurse practitioner. Dr. Harris mentioned her, Esther Mintz. Nurse practitioners are fabulous liaisons between the MD and the patient. A lot of times, patients need some guidance, and the reality is that the MD may not have the time or may not even have the knowledge base of how to guide somebody because that's not what they do. And the nurse practitioner is a fabulous liaison, so a good program has a nurse practitioner. And health education, well, for those of you in health promotion, I think that's a no-brainer. But you need somebody who can explain why you're doing this, what it means, how do you go forward, somebody who can do the smoking cessation program, who understands what it means, do the outreach. Outreach is a huge piece of lung screening programs because how does the community know about it? And the community is not just the lay community, the community is also the medical community, okay? And we also do one-on-one support, which is really, I think, the piece of our program. What we do is most of the intake is done over the phone, whether it's the patient calling me directly or it's the physician calling me with a referral. I never see these patients until the day that they come in for their screening. Because it's a CAT scan, the screenings are done at the hospital. We escort them up to radiology, and we meet them in the lobby. And the first few weeks I was doing this, it was almost like profiling, saying, oh, could that be my patient? Oh, could that be my patient? And it drove me crazy. And it was like, okay, I have to find a HIPAA way to do this. And so we just hold up a sign with their last name on it, like, you know, you get at the airport, and they meet us in the lobby, and we escort them up to radiology, and we do all the paperwork with them and do all the signatures and sit with them until it's time for them to go into the CAT scan. Why does that make a difference? One, our hospital, thank God, is growing every minute, and the physical facility is growing every day. It's very easy to get lost. So we don't want people getting lost and wandering the halls and then getting frustrated and leaving. Two, it makes them feel like they're important, which is important. Three, it helps ease the anxiety because I sit and have conversations with them. Yes, sometimes they ask me questions about the lung screening process, but most of the time we're just talking about stuff. You know, whatever. We talk about current events, we talk about things that have happened in their lives. If they're a smoker, there's always some conversation about stopping smoking. I tell them about my own experiences stopping smoking. But I sit and I talk to them. And this way they're not thinking, oh my God, I'm going for a CAT scan to see if I have lung cancer. Oh God, what if I have lung cancer? What am I going to do if I have lung cancer? That's not really an issue because there's other conversation going on. It keeps them busy. Next. Thanks. So again, the eligibility criteria is 55 to 74 with a 30-pack year history. Do you know how to calculate pack year history? It's the number of packs smoked per day multiplied by the number of years the person's been smoking. So you can get a 30-pack year history with somebody who smokes 2 packs a day for 15 years. Right? We have a lot of immigrants who come through the program. Immigrants statistically have higher rates of smoking, as do people who are low income statistically have higher rates of smoking. Well, people who are from Russia typically don't tell me how many packs they smoke, they tell me how many cigarettes they smoke. So if somebody tells me, oh, I smoke 10 cigarettes a day, I have to quickly go, oh, that's half a pack, because there are 20 cigarettes in a pack. So it's good to know that. Either currently smoking or quit within the last 15 years, as Dr. Harris said, and again, the asymptomatic, which is not on there, which I have to add. Next, please. Okay, this is what the patient's going to need. They're going to need a prescription for a low-dose CT scan, and they have to have the ability to hold their breath for 6 seconds, because what happens in the CT is that twice they have to hold their breath, and that expands the lung, so that way we can really see what's going on in there. If they can't hold their breath, they're not an eligible candidate. Next. Okay. So again, it's the low-dose CT, which is 1/10 the rads of a regular CT. It takes about 6 minutes, probably less. It takes more time to register the patient than it does for the actual test. And there's no contrast. So if somebody, I had a patient yesterday who is an Orthodox Jew, and he was very concerned because most of the time contrast is made from shellfish, which Orthodox Jews don't consume in any form. And I said to him, don't worry about it, there's no contrast, there's nothing to drink, there's nothing, no IV. You don't have to worry about deodorant or powder like you do with a mammogram. They can eat, they can take their medication, whatever. There's nothing that they can't do. And they're reading by a radiologist. Are there any questions yet? How do you address people who might have a strong history but exclusive of that age group? That's a good question, and it's probably one of the hardest things we have to do. Actually, until this past Monday, we were screening people from age 50 to age 80 because of two different criteria. The U.S. Preventive Services Task Force actually put the age range as 55 to 80, and the NCCN, the National Comprehensive Cancer Network, had the age from 50 to 55, from 50 with some other eligibility criteria, and so we were encompassing both, and we did 50 to 80, but with the CMS decision, we went to the 55 to 74. It's very hard to tell somebody that they're not eligible. I've had people who are 45 who call me, and they're still smoking, and I advise them to stop smoking and call, and well, you know, when we were doing age 50, I told them to call me in 5 years. So what happened is the NLST was done in 2010, it was published in 2011. Commercial insurance, third-party payers were not covering lung cancer screening. There were very, very few and far between companies that were covering lung cancer screening. Well something, I never remember the name of it. WellPoint. WellPoint was one of them. They're actually the umbrella agency for Empire Blue Cross Blue Shield. So if you had Empire, it was covered. But Oxford, United Healthcare, Aetna, all of those not covering screenings. And this actually became an issue for us in our program when we were forming it because, I don't know if I'm going to get kicked under the table for this later, but the reality is that hospitals are a business. No, not from you, from him. Hospitals, right. Right, it's a business, and yes, and I'm saying this to you as a health educator, as a public health person, even though there are things that are just the right thing to do because it's the right thing to do for public health issues and for the community, the reality is you have to show a return on investment. And you can have the most fabulous program, but if it's a program that, for the bean counters on the administration floor, if it's losing money or it's costing them and not bringing anything back, that program's never getting off the ground. You have to show that it's going to bring in income. It has to be able to sustain itself. When I was hired, there were decisions that I inherited, one of them being that we were going to charge patients $150 for the scan. And that was both for the scan and for the radiologist fee. It was one fee, $150, which is really almost ridiculously cheap for a CAT scan. We got such pushback from the providers that their patients didn't have the money, they weren't going to do it. We weren't getting any referrals. And it forced us to go back and look, and we were able to develop a fund to give scans at no cost. All right? I heard that's the way it should be. Theoretically, that's the way it should be. Reality-wise, it doesn't always work out that way. We were lucky enough that we were able to develop a fund. Not everybody has that luck.